Good afternoon to you all. Can you all hear me? Hello?
Yes, madam, can hear.
Okay. So the
Okay, madam, we are ready.
okay, good afternoon, everyone. So, welcome you all for the presentation. Today's case presentation done by the team from MRI, Dr. Nace, the cases, and Dr. Thamara will be joining with us with the discussion. So, I invite you all to start the case discussion. Thank you.
Good afternoon, you all. Welcome to monthly case-based discussion of the College of Chemical Pathologists. A case series with abnormal parathyroid hormone levels. Conducted by Dr. Thamara Herath, Consultant Chemical Pathologist at Medical Research Institute, Dr. Jivanti Kaushalya, Registrar in Chemical Pathology, and Dr. Nesali Panapitiya, Registrar in Chemical Pathology. Our overview lies case presentations, physiological aspects of the parathyroid hormone, case discussions. Case number 1. A 38-year-old male presented with hypertension, polyuria, polydipsia with gastroesophageal reflux disease symptoms. He had a past history of passing red color urine and having renal stones. Other than that, there's no significant past medical or past surgical history, and there's no significant illnesses in the family history. On examination, his blood pressure 140 by 95 mm mercury, and the systemic examination was normal. His blood investigations revealed a normal serum calcium level of 2.35 millimole per liter and high serum corrected calcium level of 2.57 millimole per liter and high serum ionized calcium level of 1.37 millimole per liter and low serum phosphate level of 0.8 millimole per liter. His serum magnesium level was normal, 0.88 millimole per liter, but his intact PTH level was 7.53 picomole per liter, which is high. And the vitamin D level was normal, 55 nanomole per liter. He has a serum bicarbonate level of 20 millimole per liter, which is low. To exclude the common causes of polyuria and polydipsia, we have done serum electrolytes and the other renal function test and a fasting plasma glucose level, and all the results were normal. And to exclude young hypertension causes, the common causes for young hypertension, we have done thyroid function test, plasma aldosterone-renin ratio, and 24-hour urinary metanephrines and VMA level, and all were normal. In summary, 38-year-old male presented with polyuria, polydipsia, and gastroesophageal reflux disease symptoms with hypertension, who had a past history of hematuria and renal stones, presented with high serum calcium, low serum phosphate, high PTH level with normal vitamin D level. Case 2. It's a 52-year-old lady, known patient with diabetes mellitus for 10 years. She presented after a period of defaulted follow-up
and had poor compliance with hypoglycemic drugs. She has been on Ayurvedic medication for diabetes for past 3 years. Her last serum creatinine done 2 years back was 185 micromoles per liter. On examination, he was pale, had dry skin and ankle edema, and the blood pressure was mildly elevated, which was 140 by 90 millimeters mercury. Other system examination was normal. On examination, she had a very high random plasma glucose level of 21.6 millimoles per liter and low hemoglobin level of 6.8 grams per deciliter and very high serum creatinine level of 1,238 micromoles per liter and low sodium levels 126 millimoles per liter with high potassium level 5.8 millimoles per liter. And her ionized calcium level was low, which was 1.02 millimoles per liter. The phosphate level was very high, 11.1 millimoles per liter, and the PTH level was also very high, 22 picomoles per liter, and vitamin D level was low, 12 nanomoles per liter. And she had acidosis with a pH of 7.2 and bicarbonate level of 12 millimoles per liter. So her main problems were chronic kidney disease with hyperglycemia and chronic kidney disease complicated with electrolyte imbalance, metabolic acidosis, and anemia. In summary, she's a 52-year-old lady, known patient with diabetes and poor compliance, who has been on Ayurvedic medication, presented with hypertension and ankle edema. Her serum creatinine and fasting blood sugar were very high and had low calcium, high phosphate, high PTH, and low vitamin D levels. The third case is on a 4-month-old baby boy. He presented with subcutaneous hard lumps since 1 month of age, and his mother has noticed excessive weight gain since birth. His birth history was uneventful, and his birth weight was 3.6 kilograms. His family history was unremarkable. On examination, his weight was 11 kilograms, which was over the plus 3 SD, and length was 64 centimeters, which was on the median, and OFC was 43, AF was small. He had a round space, but no dysmorphic features, and he had subcutaneous hard nodules on his limbs and had a short 4th metacarpal bone. Other system examination was normal. On investigating the patient, we found out that his serum corrected calcium level was 2 millimoles per liter, which was low, and the phosphate level was high, 2.45 millimoles per liter, and the ALP was only marginally elevated for his age-related reference range, and intact PTH was very high, 22.6 picomoles per liter. Vitamin D was normal, magnesium was normal, and the TSH was elevated with low free T4 of 0.18. His bone age was advanced, it was more than 1 year, and ultrasound brain and abdomen were normal. So her main problems were subcutaneous hard nodules, advanced bone age, excessive weight gain, and hypothyroidism. In summary, he's a 4-month-old boy with a round face, subcutaneous hard nodules, and short 4th metacarpal bone, detected to be having advanced bone age, hypothyroidism with low calcium, high phosphate, high PTH, and normal vitamin D levels.
Case number 4. A 76-year-old male presented to ETU with sudden onset of slurred speech, loss of coordination, and confusion. He had a history of generalized weakness, loss of appetite, and loss of weight for past 2 months. He had been on antihypertensives for past 12 years. There is no past medical history of diabetes, chronic kidney disease, or dyslipidemia. His past surgical and the family history was unremarkable, and he is an occasional alcoholic. On examination, he was thin-built, afebrile with dry skin. He had a heart rate of 50 beats per minute and blood pressure 110 by 70 millimeter mercury. There is no organomegaly or lymphadenopathy. He had hypertonia with diminished tendon reflexes. His blood investigations revealed a normal random plasma glucose value of 6.2 millimole per liter and serum sodium value of 138 millimole per liter, which is normal, serum potassium value of 3.5 millimole per liter, which is low normal, and serum creatinine 203.32 micromole per liter, which is high, and blood urea value of 22.1 millimole per liter, which is high. His ECG show a short QT interval and the troponin I was negative. His serum calcium was 4.12 millimole per liter, which is very high, and his serum ionized calcium level 2.24 millimole per liter, which is also very high, and serum phosphorus 0.74 millimole per liter, which is low, and serum magnesium level of 0.87 millimole per liter, which is normal, and the vitamin D 25.96 nanomole per liter, which is low, and the intact PTH value was 7.1 picogram per milliliter, which is also low. And his liver profile is normal, except a low total protein value of 58.5 gram per liter and low albumin value of 33 gram per liter and low globulin value of low normal globulin value of 25.5 gram per liter. And the CRP was 6.6 milligram per liter, which is mildly elevated. And the LDH value was 578 international units per liter, which is high. And the serum uric acid value 636.4 micromole per liter, which is also high. Further, we have done tumor markers of alpha-beta protein and carcinoembryogenic antigen level, and both were normal. The serum protein electrophoresis had revealed a faint band was seen in the alpha-2 beta interface, but his serum immunofixation was normal. In summary, a 76-year-old male presented with sudden onset of neurological deficit with bradycardia and hypertension revealed a normal random plasma glucose value with negative troponin I with very high serum calcium, low serum phosphate, low PTH with low vitamin D level.
Now we will move on to recapitulate our knowledge on physiological aspects of PTH. Parathyroid hormone is synthesized by chief cells of the parathyroid gland. It is synthesized on demand. The principal regulators are extracellular precalcium, serum inorganic phosphate, and serum vitamin D levels. Extracellular precalcium and phosphate are sensed by calcium sensing receptors on the chief cells. Low precalcium levels and high phosphate levels are stimulatory, while high calcium levels and low phosphate levels are inhibitory. Serum vitamin D levels inhibit PTH synthesis at the gene transcription level. The parathyroid hormone is initially secreted as pre-pro-PTH, that is a polypeptide hormone with 115 amino acids. And after cleavage, intracellular processing, the pro-PTH is formed, and the final product is intact PTH of 84 amino acids. Its N-terminal is the biologically active part of the protein. The secretion of parathyroid hormone is stimulated by hypocalcemia and hyperphosphatemia mainly, and serum magnesium has effects at extremely high and low values. Acute low magnesium levels stimulate PTH secretion, and high magnesium levels and chronically low magnesium levels inhibit PTH secretion. It is secreted in a circadian rhythm, and the main forms secreted from the parathyroid gland are intact PTH consisting of 84 amino acid residues and C-terminal fragments. This graph here shows the maximum PTH response in relation to ionized calcium concentration in blood. In blood, we can see intact PTH and carboxyl fragments. Intact PTH is metabolized by the liver and the kidney mainly, and the carboxyl fragments are metabolized by the kidney. The metabolized PTH and PTH fragments are excreted from the kidney. The C-terminal fragments have a longer half-life than intact PTH. The physiological actions of PTH are exerted via parathyroid hormone receptor 1, type 1. The main action is on kidney and bone, where PTH has direct actions. On kidney, it causes calcium reabsorption by distal convoluted tubule and reduce phosphate reabsorption by proximal convoluted tubule and inhibit sodium hydrogen antiphoto activity and increase stimulation of active vitamin D. On bone, the action of PTH is complex. The resorption or bone deposition depends on the PTH concentration, duration of exposure, and PTH signaling profile. The final outcome is with chronic PTH is bone resorption, and intermittent increases and decreases have an anabolic effect on bone. On the intestine, PTH has indirect effect via vitamin D, that is increased calcium and phosphate absorption. The ultimate outcome by PTH on serum is increased total and free calcium levels and decreased phosphate levels. In urine, it increases calcium excretion because the absorbed load from the intestine and added load from bone resorption exceed the renal capacity to reabsorb calcium. So the renal excretion of calcium is increased by PTH, and it increases phosphate excretion. Now we will move on to the case discussion. I would like to invite Dr. Thamara Herath to continue with the case.
First case, 38-year-old male presented with polyuria and polydipsia, gastroesophageal reflux disease symptoms, and he had past history of hematuria and renal stone formation, presented with hypertension, and investigation, there was hypercalcemia, hypophosphatemia, increased PTH, and increased vitamin D. So in this patient, initially he presented with polyuria and polydipsia. So we did common investigations like random plasma glucose, then serum electrolytes and other renal function tests like serum creatinine and serum urea. And also serum calcium levels, because there is mild nephrogenic diabetes insipidus with hypercalcemia. So with those investigations, we found that there is hypercalcemia. Therefore, together with that investigation finding, we did serum phosphate, PTH, and vitamin D levels to make the interpretation easier. So we found that there is hypercalcemia with hypophosphatemia, increased PTH, and increased vitamin D. So the differential diagnosis include primary hyperparathyroidism and familial hypocalciuric hypercalcemia. So we did urine investigations. Calculated calcium excretion is 0.7 millimoles per day, which is very low. And calcium to creatinine clearance ratio was 0.002, which is also low. And if the level is less than 0.01, it is suggestive of familial hypocalciuric hypercalcemia. And if it is more than 0.015, it is suggestive of primary hyperparathyroidism. So this is a case of familial hypocalciuric hypercalcemia. We did family screening also. In that, the patient's urine calcium excretion of the patient mother, daughter, his sister, and his son. All these excretion levels were low, supporting the diagnosis of familial hypocalciuric hypercalcemia. And genetic confirmation needs to be done. So when we compare these two entities, primary hyperparathyroidism and familial hypocalciuric hypercalcemia, there is clinical and biochemical overlap between these two entities. When we look into pathogenesis in primary hyperparathyroidism, there is hypersecretion of PTH from parathyroid glands, usually due to parathyroid adenoma, and occasionally it's due to parathyroid hyperplasia and rarely due to parathyroid carcinoma. In familial hypocalciuric hypercalcemia, there is loss of function mutation in calcium sensing receptor gene, leading to defective calcium sensing receptors in parathyroid and also in kidneys. So because of that, with normal or mildly elevated calcium levels, this calcium sensing receptor, as it is defective, there is continuous PTH secretion. And in kidneys, this urinary excretion of calcium is not done. So there is hypocalciuria. Symptoms of hypercalcemia are similar in both, and serum calcium in both can be high or normal. Serum phosphate can be low or normal in both. And active vitamin D is high in primary hyperparathyroidism because PTH stimulates 1-alpha hydroxylase, thereby forming active vitamin D. And in FHH, it is normal. PTH levels also can be high or normal in both. So the most important investigations are urinary investigations. First, we need to do 24-hour urine calcium excretion test, followed by urine calcium to creatinine clearance ratio. So in primary hyperparathyroidism, it is more than 0.015, and in familial hypocalciuric hypercalcemia, it is less than 0.01. Management-wise, in primary hyperparathyroidism, it is managed by total parathyroidectomy, and in familial hypocalciuric hypercalcemia, conservative management plus or minus calcilytics and calcimimetics. It is important to highlight in this situation the importance of differentiating between these two entities, where clinical features and biochemical features, there is the overlap of these two, and in these two entities, and it is important to do urine calcium to creatinine clearance ratio because the management is quite different. Case 2, a 52-year-old lady presented with, she is a diabetic with poor compliance on Ayurvedic medication with hypertension and ankle edema. Her serum creatinine levels was increased with increased fasting plasma glucose. She had hypocalcemia, hyperphosphatemia, increased PTH, and decreased vitamin D. So there is renal failure with hypocalcemia, hyperphosphatemia, and decreased vitamin D, and which lead to increased PTH secretion. So this is a straightforward diagnosis: renal failure induced secondary hyperparathyroidism. In renal failure, what happens is there is decreased calcium reabsorption at distal converter tubules, leading to hypocalcemia, decreased phosphate excretion at proximal converter tubules, leading to hyperphosphatemia. Both hypocalcemia and hyperphosphatemia stimulates PTH synthesis and secretion from parathyroid glands. In addition, there is decreased renal parenchymal cells, so there is impaired vitamin D synthesis. Usually, for PTH synthesis, active vitamin D inhibits its synthesis. But in this case, since the vitamin D synthesis is impaired, there is impaired inhibition of PTH synthesis. So hypocalcemia, hyperphosphatemia, together with impaired inhibition of PTH synthesis, lead to continuous stimulation of PTH secretion, causing secondary hyperparathyroidism. So this patient was managed for fluid overload with fluid restriction and loop diuretics, hyperkalemia with potassium restriction, hypocalcemia with calcium supplementation, hyperphosphatemia with dietary phosphate restriction, metabolic acidosis with IV bicarbonate, and anemia with IV iron supplementation after obtaining blood for iron studies. Patient is awaiting hemodialysis. Case 3, a 4-month-old baby with round face, subcutaneous hard nodules, short fourth metacarpal bone, advanced bone age, and hypothyroidism with hypocalcemia, hyperphosphatemia, increased PTH, and normal vitamin D levels. So clinically, he had round face, subcutaneous ossifications, actually subcutaneous hard nodules, short fourth metacarpal bone, advanced bone age, and excess weight gain. So these are the features suggestive of Albright hereditary osteodystrophy. Because of these features, we did serum calcium, phosphate, PTH, magnesium, and vitamin D. And patient had hypocalcemia, severe hyperphosphatemia, high PTH, together with normal magnesium and vitamin D levels. In addition, he had hypothyroidism. So the biochemical picture of hypocalcemia, hyperphosphatemia, high PTH with normal magnesium and vitamin D in a clinical picture of Albright hereditary osteodystrophy is suggestive of pseudo-hypoparathyroidism. Pathogenesis. Pseudo-hypoparathyroidism is a heterogeneous group of rare inherited disorder. It occurs due to heterozygous inactivating mutation in the GNase1 gene that codes for alpha subunit of the stimulatory G protein. There is resistance to PTH plus or minus other glycoprotein hormones which act via stimulatory G protein such as TSH, LH-FSH, and growth hormone releasing hormone. So in our patient, there is resistance to PTH. So PTH can't exert its action. Therefore, there is hypocalcemia, hyperphosphatemia, and because of this resistance, there is increased PTH production. In addition, our patient had hypothyroidism. Since he has normal excessive weight gain and there is no defect in growth, we didn't do growth hormone levels, and he is only 4 months old baby boy, and in this case LH and FSH are indicated only when there is delayed puberty. So in this patient, it was not indicated. Pseudo-hyperparathyroidism type 1A and type 1C result due to maternally inherited inactivating GNase1 mutation, which manifest with AHO phenotype and hormonal resistance. So our patient had both of these. He had AHO phenotype and hormonal resistance evidenced by increased PTH together with hypocalcemia and hyperphosphatemia. Pseudo-hypoparathyroidism results due to paternally inherited GNAS1 mutations which manifest with HO phenotype alone with no hormonal resistance. That is why pseudo-hypoparathyroidism mimics the clinical picture of pseudo-hypoparathyroidism. Since there is no hormonal resistance, those patients are biochemically normal. That means they have normal calcium, phosphate, and plasma PTH level. Pseudo-hypoparathyroidism type 2 results due to methylation abnormalities of GNAs, which manifest with hormonal resistance. So that's why these pseudo-hypoparathyroidism type 2 patients also has biochemical evidence of hypocalcemia, hyperphosphatemia, and increased PTH. But they don't look like pseudo-hypoparathyroidism type 1. There is no HO phenotype. The same thing depicts in this picture. You can see parathyroid hormone acts via parathyroid hormone receptor, type 1 receptor. And when there is a mutation in GNAS1 gene, if it is, it affects stimulatory G protein of parathyroid hormone type 1 receptor. If it is inherited as maternal inheritance, there occurs pseudo-hypoparathyroidism type 1, causing both renal and bone resistance. So they have both HO phenotype as well as these hormonal features, increased PTH in this case. If the mutation inherits from paternal inheritance, there occurs pseudo-hypoparathyroidism, where there is bone resistance. So they have HO phenotype, but there is no hormonal imbalance. When the defect is in the downstream, in DNA methylation, as DNA methylation defect, there occurs pseudo-hypoparathyroidism type 2, where these patients have renal resistance only. So they are biochemically, there is hypocalcemia, hyperphosphatemia, and increased PTH, but there is no HO phenotype because there is no bone resistance. Few words about Albright hereditary osteodystrophy. This phenotype is commonly observed in pseudo-hypoparathyroidism type 1A and type 1C, in pseudo-hypoparathyroidism, and pseudo-hypoparathyroidism type 1B rarely, and it is not described in pseudo-hypoparathyroidism type 2. Subcutaneous ossifications in AHO. This ectopic ossification is another characteristic feature of AHO. They are extraskeletal bone formations or intramembranous ossifications. So this is a result of stimulatory G protein alpha deficiency in the mesenchymal stem cells, leading to their differentiation into osteoblasts at extraskeletal sites such as subcutaneous tissue and dermis. So there occurs new bone formation in subcutaneous tissue. Mind you, this is different from ectopic calcification, which is associated with changes in calcium and phosphate metabolism. This solely depends on stimulatory G protein alpha deficiency in the mesenchymal stem cells, and this is not ectopic calcification but extraskeletal bone formation or ectopic ossification. So our patient was managed with thyroxine for hypothyroidism and osteocare for his hypocalcemia. Case 4. A 76-year-old male presented with sudden onset neurological deficit, bradycardia and hypotension. Since he had a sudden onset neurological deficit with confusion, first line investigations like random plasma glucose, serum electrolytes and renal function tests were done, and only serum creatinine and urea were elevated. Since he had bradycardia and hypotension, ECG and troponin I were done to exclude myocardial infarction. His troponin I was negative, but his ECG showed short QT interval. Because of this short QT interval, we further investigated for serum calcium levels. It was 4.12 millimoles per liter, which was highly increased, that is more than 3.5 millimoles per liter, which suggests some form of malignant type of increase in serum calcium levels. Ionized calcium also elevated 2.24 millimoles per liter. Phosphorus 0.74 millimoles per liter, which was low. He had normal magnesium level. Vitamin D was decreased 25.9 nanomoles per liter, and intact PTH was decreased 7.1 picograms per milliliter. His liver function tests were normal except total protein, total protein and albumin. CRP elevation was not that significant. Lactate dehydrogenase and uric acid levels were elevated, further supporting the diagnosis of malignancy-induced hypercalcemia. So we did some Q markers like alpha-fetoprotein and carcinoma membrane antigen. Both were normal, and serum protein electrophoresis showed a faint band in the alpha-2 beta interface, but his serum immunofixation was normal. Radiological investigations, chest X-ray showed multiple osteolytic lesions in the ribs. Ultrasound scan, neck and abdomen were normal. 99 technetium whole body scan showed moderately increased uptake in right and left side ribs. Hematological investigations, full blood count was normal. ESR was 55 millimeters in first hour. Blood picture showed normochromic normocytic anemia and neutrophil predominance with myelocytes and promyelocytes and atypical cells. Bone marrow aspiration, there were more than 90% of abnormal cells. Trephine biopsy, marrow filled with abnormal cells. So it was diagnosed histologically as Philadelphia negative BALL, and he was started on chemotherapy. So in this patient, severe hypercalcemia together with hypophosphatemia, short QT interval, low intact PTH, and decreased vitamin D. All these suggestive of tumor-induced hypercalcemia. So in addition, there is increased lactate dehydrogenase and uric acid levels with lytic lesions in bones. And finally, he was diagnosed with BALL. So it's a straightforward diagnosis of tumor-induced hypercalcemia. So what are the common mechanisms responsible? Parathyroid hormone-related peptide mediated humoral hypercalcemia, acts on calcium sensing receptors on osteoblasts with subsequent activation of osteoclasts and bone resorption. Osteolytic metastasis related hypercalcemia occurs in breast cancer and hematological malignancies via local osteoclasts, activating factors like cytokines, rank ligand, interleukin 3 and 6. Active vitamin D mediated hypercalcemia as occurs in lymphomas and ovarian germ cell tumors. Then parathyroid hormone mediated hypercalcemia in parathyroid tumors and extraparathyroid cancers such as ectopic secretion of PTH in small cell lung carcinoma and adenocarcinoma. So in our patient, intact PTH level is decreased, so it can't be PTH mediated hypercalcemia, and active vitamin D levels also decreased, so it can't be due to active vitamin D mediated hypercalcemia. So we left with these two, and it is probably due to osteolytic metastasis related hypercalcemia because hematological malignancies via local osteoclast activating factors, it causes hypercalcemia. In our patient, it's a hematological malignancy and there are osteolytic lesions in ribs. We can't exclude parathyroid hormone related peptide mediated humoral hypercalcemia because it also acts on calcium sensing receptors on osteoblasts with subsequent activation of osteoclast and bone resorption. So osteolytic lesions can be due to that also. And there are combination of mechanisms. So for that, we need to do PTH-RP levels, which is unavailable for this patient. Thank you.
Thank you, Thamara and the team. The forum is open for the questions. In the second case, is the patient presented with the renal failure itself and all the features with hypercalcemia?
Yes, madam. She hypocalcemia presented with features of renal failure and hypocalcemia.
Both. Okay.
Yes.
So straightforward, they went for the like dialysis with the high creatinine. They did.
Yeah, they were waiting dialysis, madam. Now she must have undergone dialysis.
Okay. Any questions from the audience? There's a question in the chat box. Can FBHH present with renal stones? FBHH present with renal stones.
Yes, but it usually occurs with primary hyperparathyroidism, but there are documented cases.
Okay. Any more questions? You can also post in the chat box.
And hypertension also associated with primary hyperparathyroidism. So initially we thought of the diagnosis is primary hyperparathyroidism, but once we went on doing urine investigations only, we diagnosed it as familial hypocalciuric hypercalcemia because symptoms are more suggestive of primary hyperparathyroidism, but they can occur in, usually these renal stones, they can occur in FHH as well.
So it's it's indicate that the importance of doing like with the broad mind and in both in serum and urine investigations in suspected patients, I think.
Yes.
Any more questions from the audience? So in the absence of questions, I invite Dr. Dilanthi to give the vote of thanks.
Thank you, Dr. Dulani. Hope you all can hear me. Can you all hear me?
Yes, madam.
Yes.
Okay.
Yes.
So thank you. First of all, let me thank Dr. Thamara Herath, Consultant Chemical Pathologist, Medical Research Institute, for organizing this event and guiding the trainees and for delivering a very comprehensive presentation on this case discussion. Thank you very much, Dr. Thamara. Next, our sincere thanks goes to Dr. Jeevani Kaushalya, Registrar at MRI, and Dr. Nesali Panapitiya, Registrar in Chemical Pathology at MRI, for their excellent presentations. We are also grateful to all the participants who joined us today and those who encouraged us with this discussion also. And so we have come to the conclusion of this session. Hope to see you all in another interesting session like this in next month. Thank you.